Affordable Care Act, payer and public option health reforms, ERISA preemption of state health laws, consumer financial protections for patients, and healthcare consolidation and prices, as well as surprise medical billing. So she's covered a lot of ground. Today she is going to focus primarily, or I think solely, on private equity and the corporatization of healthcare. This is drawing, I think, somewhat at least from the Stanford Law Review paper that is forthcoming in 2024. So exciting to be able to hear that work. That's really fresh. Though, as I said, she has published in a number of law review journals, but also in a number of health policy journals, has two publications out this year in 2023, one in Journal of Health Politics, Policy and Law, which is dear to my heart, on options, legislative and regulatory options to improve Medicare Advantage. So would love to have you talk about that. And then another one on that got a lot of press, New England Journal of Medicine. The title of that one is Corporate Investors in Primary Care, Profits, Progress, and Pitfalls. So look to that one as well. So welcome.
Thank you so much, Colleen, and to Joe Brush for inviting me, and to the faculty and staff of the Center for Health Administration Studies. It is such a delight to be here. I was telling everyone, thank you for ordering the perfect weather. It seems like this is the most beautiful day to be here, so I really appreciated that. So yes, I'm here to talk primarily about the paper that I have coming out on private equity and the corporatization of healthcare, but in a nod to the theme of the series, I changed the title of today's presentation to focus on the financialization of healthcare, because I think the two are intertwined, and certainly related. And I'm increasingly convinced that is one of the issues that is driving public policy concern about private equity in the healthcare space. So I think what I have been told is that this group sometimes likes to raise hands along the way. So if there are questions you have, I'm a law professor. I'm used to being interrupted. So feel free, if there's a pressing question, you can save it for the end, or if it just comes to mind right then, I'm happy to answer it. So feel free to raise your hand. But otherwise, we'll take questions at the end. All right, so my journey down the private equity rabbit hole really got started when I started looking at the topic of surprise medical bills. These are those unexpected bills that you could receive for inadvertently seeing an out-of-network provider, such as an emergency, right? You're in an emergency room, you can't choose your provider. Or when you go to an in-network facility, but you have an out-of-network physician or someone providing you care at the in-network facility, like an anesthesiologist that you didn't choose. So these are not generally covered by your insurance and are much higher in cost than your in-network services would be. And I, like everyone else, was wondering why we were suddenly seeing an explosion of surprise medical billing. Even though out-of-network balance billing had been technically possible for decades, it was only in the last decade that we really saw them proliferating in terms of their frequency and scope. The answer, it seemed, was private equity. Private equity was willing to use the out-of-network billing strategy as a revenue strategy way more than providers had ever done before. And so private equity identified a market failure or a payment loophole that it could monetize, and it went in and it did just that. It capitalized on those payments, and so we saw sort of an overnight explosion of these out-of-network bills. So this led to a larger inquiry into private equity investment in physician practices more broadly. Because what was going to be the next surprise billing type of payment loophole that would attract private equity into the healthcare space, particularly into physician practices, and what are the harms that would then ensue for patients and payers and the community, the society at large? So I worked with colleagues at the USC Brookings Schaefer Initiative to try to figure out that question, and that is the tiny divining rod paper in the lower left-hand corner. So we mapped out where private equity was moving in the physician practice space and try to figure out what financial engineering loopholes were drawing the investments into these different subcategories of specialties. And then Mark Hall, another law colleague of mine who was on that project, and I decided to write the long law review paper, which is sort of the subject of this talk, which is really kind of unpacking what are the legal and policy tools and levers that we have to get at some of the risks that we're seeing developing from private equity investment in healthcare. So that is the subject of today's talk. All right, so here's an overview of where I'm going to go today. First, I'll just start with some trends of private equity investment in healthcare and the private equity model as a descriptive matter. Second, I'm going to identify some of the potential harms from a public policy standpoint that private equity may pose to patients, to physicians, and workforce, as well as to the healthcare market overall. And then we're going to talk about how we develop this methodology to figure out what to do about it, right? What do we do about these harms? So to figure out what policy levers to pursue, we have to ask, what is that revenue strategy that is driving investment into a particular market segment? This is where we're going to go into the weeds. Once we identify the payment loophole that is being exploited, then that tells us where to target with our policy action or our enforcement of existing laws. Finally, I'm going to discuss what those potential legal and policy levers might look like that we could use to address the harms and the playbooks that private equity investment is using in healthcare. All right, so just trends. There's been a significant increase in private equity investment in healthcare overall. This is actually a pretty old slide. It ends in 2020, and the number, of course, the pandemic happened, and that affected investment activity, and it ticks up further. It resumes force after that. So there has been from an industry-wide standpoint, so across healthcare, not just hospitals, not just physicians, but across the healthcare industry, it has grown roughly 2,000% in roughly 20 years from 2000 to 2018, or in dollar terms, from a $5 billion investment in 2000 to a $100 billion investment in 2018. And over the past decade, the estimated total deal value in current dollars is, some estimates put it at about 750 billion, others say it's 100 billion. It's a lot of money just in one decade. So more recently, that trend has shifted from focusing on hospitals and nursing facilities to physician practices. I'm sorry that the font is so small. I can share these slides, but all of these are actually from the publications themselves. So if you want to drill down, I'm happy to share them. So private equity investors have moved to physician practice specialties very, very rapidly over the last few years. So they have increased from about 39 deals annually to 221 deals just from 2010 to 2019. So that doesn't sound like it's a lot of deals, but it involves nearly 1,300 deals total and thousands of physicians involved. So when we look at private equity deal data over the last decade, we see that private equity has not only entered the physician market aggressively, but it has targeted particular specialties more than others. It's not entering all physician specialties at an equal level, right? So it's targeting certain types of physician specialties, and we have to ask why. Why are they targeting certain physician types and not others? And so we lumped these into three main categories. The first are hospital-based physicians. These are physicians like emergency room doctors, anesthesiologists, radiologists who really practice their profession out of a hospital. The second are office-based specialties. These are dermatology, ophthalmology, gastroenterology, orthopedics, and those types of office-based specialties. And the final category were value-based and primary care practices. These are sort of you think of as primary care physicians, but also women's health and other types of specialties that often are paid on a value-based payment model. So as I'll describe in a minute, private equity investors have identified a different revenue strategy or multiple revenue strategies for each one of these categories, depending on how they're paid in the market structure for that specialty. But before I get into that, I'm just going to summarize the private equity model for those who might not be taking Professor Brush's class. So the one is the financial sponsor the private equity firm is comprised of a general partner who basically calls the shots from an investment standpoint, and also limited partners. These are the investors who are basically investing pension funds, endowments, sovereign wealth funds, wealthy people, right, contribute the investment capital alongside the private equity general partner to form the capital contribution of the PE fund. 30% of the PE fund's investment dollars are this equity, right, this combination of general partner and limited partner funds. But the general partner only contributes 2% of the equity. What it's really contributing is its management expertise, its strategic oversight. They use that 30% equity to access about 70% of leverage, meaning debt. And that debt is then what we call a leverage buyout, right? So a leverage buyout is the idea that you use a small amount of equity to leverage a larger amount of debt, and then that total amount can be used to go out and buy a target or multiple targets. In this case, it could be a hospital, it could be a nursing home, it could be physician practices. So the overall financing structure, again, is usually 30% equity, 70% debt. The debt, though, is secured not by the assets of the PE fund, it's secured by the target. So the assets of the physician practices, the assets of the hospital. So what does that look like? For physician practices, it's usually net patient revenue. That usually physician practices don't have a lot of hard assets in the form of real estate or equipment. They might have some, but a lot of it is that net patient revenue. So the general partner, again, only contributes 2% of the equity, but it stands to earn 20% of the take-home profit, meaning that's what's also called the carried interest. So what it earns is 20% of the profit, and the profit is usually earned at exit. So they have to sell the company, and they have to sell it with a certain rate of return called a hurdle rate in order for it to earn its 20%. And so that creates, as we'll get to, a little bit of an incentive, or a lot of an incentive, to quickly maximize profits over that short 3 to 7 year time window. The limited partners contribute 98% of the equity, but they stand to earn 80% of the profits. So notice it's the private equity investment fund that reaps the profits from the portfolio companies, in this case, the physician practices, and in return, the portfolio company receives an infusion of capital. What else are they getting? Is it just money that they're getting? Well, they do want that capital, right? That things are expensive. Health information technology is expensive. Electronic health records are expensive. But what they really want is a manager. They want management services. And so the private equity fund doesn't always directly outright buy the physician practices. What it does is it stands up a management company that contracts with the physician practices to run the practices in exchange for a cut of the revenue. So the overall time horizon varies, but typically the private equity fund hopes to exit the investment in, like I said, a short period of time, relatively speaking, 3 to 7 years, maybe a little bit longer, but it hopes to make in that short time period 200 to 400% returns on its initial investment. Again, so that requires it to rapidly increase revenues and profits of the portfolio companies, reduce costs, and then sell the company in an exit in order to achieve that 20% return. So there are 3 exit strategies that are typically taken. The majority of them are to a secondary private equity company, but there is also sale to other corporate strategic investors, such as publicly traded companies. Optum, CVS, Amazon might be a buyer. And occasionally they will take the company public, and also occasionally, not listed on here, the target company will go bankrupt. All right. So in the case of physician practices, private equity investors use this platform and add-on model where they basically buy a lot of small practices and roll them up or add them on to a platform practice in order to grow the size of the target company. So the private equity firm selects a platform practice, which is a high performing, meaning a high revenue practice with a lot of good desirable market position, both geographically and in terms of its patient base. And then what it does is it grows that practice by buying up other small practices in that specialty and in that area. And so it adds all of those together to make a bigger footprint. And it increases the revenues, it increases the valuation, right? A bigger company means more market share, more ability to raise prices, more revenues, more profits, more ability to leverage that same smaller amount of equity to a larger amount of valuation because it's a larger sized company. And these are highly leveraged purchases, so consolidation is in itself a revenue strategy to grow the value and the return on investment for the investor's capital. So private equity sponsors form, as I mentioned, a management company, a management services organization that manages the operations of its portfolio company. The platform and add-on model explains how private equity investment into physician specialty markets consolidates those markets, right? You can see that it takes a fragmented market and wraps all of those up into one giant player. And so for payers and insurers on the purchasing side of the equation, it is very difficult to try to negotiate against a large rolled up practice because they control the market, right? And so they have the market power to raise their prices. Okay, so one question I often get, and I stole this, I borrowed, with permission, this slide from Atul Gupta, but what is the difference between private equity from other corporate investors? Is this a different in kind or different in degree? And I would say it's mostly a difference in degree, but there are a few distinguishing characteristics that make private equity a little bit different than a traditional investor. So there are three features that distinguish private equity. The first is that private equity investment is highly leveraged. So compared to traditional investment, it adds a significant debt burden onto and loads it on the target company. So that is not always a feature of regular investment in healthcare companies, is that debt. And then it operates on a very short time horizon, right? That 3 to 7 year exit is necessary for the private equity fund to earn its returns. This is not true of traditional corporations that might be operating an entity as a going concern indefinitely, right? So it doesn't need to sell, it doesn't need to exit in order to earn returns. This creates this combination of highly leveraged short time horizon creates moral hazard, right? So private equity reaps all the upside of rapidly increased revenues, but it doesn't bear the risks of loss because the debt is on the target company. Losses are limited to its capital investment, which is small. And because it's not a repeat player in the industry, it doesn't have reputational capital or regulatory capital at stake. All right, so there are three main risks that policymakers are concerned about that this private equity investment is creating, particularly in the physician practice space. The first is consolidation and cost increase, right? I've mentioned how this roll-up strategy consolidates markets. But we also see potential cost increases from the strategies used to increase those revenues, whether it's upcoding or aggressive risk adjustment methodologies, things, again, that don't necessarily add value to patient care, but increase the costs to society. The second harm is to patient care itself. This could look like staffing reductions. It could look like cost cutting, right? So there's not only an effort to increase revenues, there's a simultaneous effort to reduce costs. So that could look like changing the amount of staff or the sophistication of that staff, closure of less profitable services and facilities, which could directly affect patient access to care. And then finally, the third harm is harms to the physicians and advanced practice practitioners, the clinical workforce themselves. You might be seeing a lot of headlines about physician burnout, about moral distress, about nursing shortages, about exit, about inability to attract new trainees into the fields of, say, primary care or emergency medicine. Loss of physician autonomy, loss of clinical oversight, or at least clinical decision-making authority, is all driving, in some ways, it may not be the sole driver, but it is driving this harm to the workforce, I think, that is only now starting to be studied in terms of how are these affecting the experience of physicians and clinicians who are practicing in these new corporate models. This is one of the slides from Professor Brush's work. So we are starting to see that these aren't just theoretical harms, right? It's very difficult to quantify, to disaggregate, measure when these changes are occurring. But we are starting to see that there are some changes in terms of certainly spending, charges, prices, and other types of measures of cost increase are being documented. And the literature may be emerging as well on the quality and patient care side. And as I mentioned before, there's anecdotal evidence, but I'd like to see more empirical evidence on the experience of the sort of things like physician burnout and clinical workforce issues as well. All right, so what does that mean? Well, I think that in addition to these discrete harms, this is sort of where it's sort of touching into this theme of financialization, that there's a more troubling harm that's emerging from this whole picture. And that is that private equity investment in healthcare is driving a trend toward the financialization of healthcare. And this isn't solely the product of private equity investment. There are lots of other corporate actors who are participating in this financialization. But private equity is sort of the most visible version of this. And what I mean, and I think hopefully we can have a conversation with my colleagues here, what we mean by financialization in healthcare is this idea that investors can mine healthcare service organizations to extract wealth for themselves, for the investors, for the officers and directors, for those who are standing to profit from these investments, but not to patient care, right? These are not even going into the pockets of the physicians, the clinicians, the providers themselves. It's certainly not going to more better patient care services. And so that's what we mean by financialization, is like taking all of this excess spending and putting it in the pockets of those who stand to profit. So the primary goal of a financialized healthcare system, like any financialized product, is profit, right? Whether it's to maximize shareholder value or returns for the private investor, while quality of patient care is secondary. It's a secondary concern, and cost control is anathema, right? Cost control is a reduction of profit. So if something saves money for the healthcare system and for payers at large, that is a reduction in potential profits for them. So the main problem with a financialized healthcare system is this sort of mismatch, right, between the incentives it sets up to maximize revenue and our overall societal goal to reduce healthcare spending, bend the cost curve, and also increase access to quality patient care. So what do we do about it? So one of the things that my colleagues and I did in that sort of divining rod paper was to try to follow the money, essentially, to use private equity investment as a divining rod to find market dysfunctions and payment loopholes. Robbers rob banks, the saying goes, because that is where the money is. So same thing, the same premise applies here. Follow the private equity investment to find where they are targeting, because they have found a source of revenue. Once we can figure out what that source of revenue is, then we could look to see whether there are any sort of payment loopholes that are being exploited and potentially target a policy response at identifying those payment loopholes, closing those payment loopholes, and changing some of the incentives there. So let's start with let's use this strategy in that category of hospital-based physicians. So the revenue playbook, one of the revenue playbooks, motivating private equity investment in hospital-based physicians, such as emergency physicians and anesthesiologists, was an out-of-network billing strategy. So about a decade ago, private equity investors like KKR and Blackstone moved heavily into hospital-based specialties. And what makes hospital-based specialties unique is that patients don't choose these physicians. So their patient volumes do not depend on being in network with your insurance plan. So private equity had identified a payment loophole where emergency physicians could effectively leave provider networks, leave health insurance plan contracts, and demand higher out-of-network payments because health plans are required by law to cover emergency services regardless of their in or out of network. And then the emergency physician, if they're out of network, can not only demand a higher price from the health plan, they can turn around and balance bill the patient, that is a surprise bill, for the difference between what their full charges are, their sticker rate, their rack rate, and whatever amount they got reimbursed by the health insurance company. And they can do all of this without losing a single patient in volume, right? Their reputation doesn't matter, right? You don't go to an emergency room because you go to an emergency room because you're unconscious and you're taken there by an ambulance, right? So that was the strategy that the private equity investors figured out. So researchers started to tie the increased use of surprise billing to the entry of private equity into emergency physician staffing firms like Envision and Team Health. So patients and purchasers were of course harmed because they were being hit by these huge unexpected medical bills. Payers were seeing their in-network negotiated rates go up because of the threat of leaving the network, right? Like, I don't have to stay in this network, you're going to pay my higher rates. And then surprise billing then generates this huge outcry and prompts dozens of states and eventually even the federal government to pass a law to outlaw surprise billing, surprise medical billing. However, before the bill eventually passed, private equity investors poured millions of dollars in dark money campaigns and direct lobbying of key members of Congress to try to thwart the law's passage. Congress eventually did pass the law. It's still being litigated by physician groups and other private equity-backed litigants from being fully implemented. But that was a huge and politically charged policy solution to a problem that was largely driven by private equity's entry into the hospital-based physician market. Note, just this past May, KKR-backed Envision, the ER staffing company that was built on an out-of-network balance billing strategy, announced it would file for Chapter 11 bankruptcy. So this collapse is due in large part to the fact that the No Surprises Act ended out-of-network surprise bills, and that's what we mean by a playbook and a policy response, right? You figure out what the playbook is, and then you craft a policy response. Okay, so what's the revenue playbook behind the other types of entry into office-based strategies? There's a different revenue strategy at play for office-based strategies, specialties like dermatology, ophthalmology, gastroenterology. These are specialties that engage in a lot of outpatient procedures. They're typically reimbursed on a fee-for-service basis, and their revenue playbook is to maximize, to grow the market, right, consolidate, maximize steady commercial and Medicare revenue for services that can be counted on to be provided on a high volume, plus supplement it with cash revenue, imagine things like LASIK, cosmetic dermatology. And in particular, these practices can self-refer a number of lucrative wraparound services. These are ancillary services like physician-administered drugs, physical therapy, pathology labs that can all be billed and captured. All that revenue can be kept within the practice. So the strategy is to capture the market, grow your market share, increase the volume of patients, self-refer for procedures and services, increase the intensity of those procedures, and reduce staffing levels, all of which to increase revenue. So the risks are that this leads to consolidation of that market if all the practices are rolled up into one giant investor-backed practice, which can lead to higher prices, unnecessary services, and potentially understaffed or inadequately supervised care. So for primary care, there's another revenue strategy at play. It seems that the corporate investors here have figured out a way to exploit the ability to game coding practices to increase risk-adjusted payments from Medicare Advantage and other value-based payment models. So one strategy private equity firms have pursued is to invest in and expand practices that serve a large number of Medicare Advantage patients, or actually combine the practice and the Medicare Advantage plan, so you own the whole thing from soup to nuts. And the revenue strategy is to extensively, aggressively code, maybe even exaggerate Medicare patients' diagnoses and comorbidities, which increases directly the federal payment you get for that patient on a capitated basis. That translates to more revenue for investors. So besides upcoding under a value-based payment model, the financial incentive can also be to stint on care. If anyone's heard about the prior authorization scandals of some of the Medicare Advantage plans, that is stinting on care. You can also try to cherry pick healthy patients. There's also an incentive to reduce costs by substituting less expensive providers for physicians. That's not necessarily bad for care, unless they're all seeing such a high volume of patients that patients are basically being moved through the system too quickly to actually manage their chronic or complex healthcare needs. Okay, so now what do we do about it? So on the various policy levers, right? Once we identify those revenue playbooks, now we can start to identify policy levers. Private equity has shown a penchant for taking advantage of so many different loopholes. Therefore, one policy solution is to close the payment loophole that private equity has helpfully identified for us. So the first one, of course, the example was the No Surprises Act. Again, it wasn't easy to pass the No Surprises Act and state surprise billing laws, but that was find a loophole that's being created by existing payment policy and close that loophole. Another loophole that could be closed in a similar way would be to change the way Medicare Part B pays for physician-administered drugs. I warned you this was going to go way down in the weeds. That's what the private equity investors do, is they figure out very specific rules and loopholes to exploit. So one is this Part B payment policy. So Medicare's way of paying for physician-administered drugs under Part B of the Medicare system is tied to the percentage of the list price for that drug. So what does that do? For ophthalmologists, what it does is it says ophthalmology drugs to treat wet macular degeneration, you have a variety of choices, each of which are clinically equivalent, but one costs 40 times more than the other. So a private equity company can buy up ophthalmology practices and shift overnight the prescribing practices of all acquired physicians to the more expensive drug and overnight increase the revenue of that practice. So that is one way, again, if you change the way Medicare Part B pays for these drugs, you could close that payment loophole. Same thing, you could do the same thing with the Medicare Advantage coding policy about how Medicare Advantage plans try to get at the risk code gaming that these Medicare Advantage plans engage in. So those policies could be tightened as well. None of which are easy, right? Some of those involve new statutes, not just new regulations. Another another policy lever or legal lever is antitrust enforcement. So one of the concerns that sort of involves all this sort of physician practice roll-ups is that it contributes to consolidation of the physician specialty market. So there is evidence that in some localities, private equity penetration has increased 40 or 50% of the specialties in that, of the market share of that specialty in that local area. Meaning if you were to go out and try to find a gastroenterologist in the Atlanta area who's not private equity owned, good luck. I tried. It was very difficult. But because the value of each one of these individual transactions is typically, pretty small in the scheme of federal antitrust law, it falls below the mandatory reporting threshold under the Hart-Scott-Rodino Act, which in 2023 is $111.4 million per transaction. So it doesn't even get reported to federal antitrust authorities unless the value of that transaction exceeds $111.4 million. They tend to go unreported and they fly under the radar and they therefore get unreviewed by federal antitrust authorities. So what can we do about this? At the federal level, we could reduce that threshold under the Hart-Scott-Rodino Act for healthcare acquisitions. We could accumulate the value of serial transactions that are used and have a look-back period of months or years. So that would be one way to trigger the reporting. But recently, the FTC has started to take some very promising steps to increase antitrust scrutiny over these private equity physician roll-ups. One is the recent draft merger guidelines that came out this summer announced that the antitrust agencies will look at serial add-on acquisitions for cumulative impacts on the market, not just individually. So that's a step forward. And then second, this past month in September, the FTC brought a major case against the US Anesthesia Partners and its private equity owner, Welsh Carson, alleging that USAP and Welsh Carson used a roll-up strategy to monopolize the market for anesthesia in Texas in a way that violated the antitrust laws. So stay tuned on that case. So in addition, states could also have their own parallel antitrust enforcement authority. So states can also take steps to look at transactions, particularly those that fall below that Hart-Scott-Rodino threshold. And several states, including Massachusetts, Oregon, and California, have done just that and have the ability to stop or place conditions on those transactions before they happen. What's another policy lever? So private equity firms' emphasis on increasing profits of acquired practices may increase risks of overutilization, of overbilling, of upcoding, for making improper self-referrals for ancillary services. And all of those same pressures to maximize profits could also lead to stinting on less profitable services or patients, or increase the use of non-physicians. Again, not in itself bad, but it could be done in a way without adequate supervision that doesn't justify the level of billing. So all of these threats to patient care and healthcare spending could be addressed by existing laws. Federal laws include fraud and abuse laws like the False Claims Act, the anti-kickback statute, and the Stark Law, all of which could be deployed against some of these practices if they were scrutinized. So stepped up enforcement under these laws, whether by the government, whether by private whistleblowers who are in a position to see these practices underway, could address some of the fraud and abuse risks posed by private equity investment in physician practices. And because private equity funds, through their management services organizations, assume very active management control over the operations of their acquired practices, it's going to be easier actually for the government to not stop with assigning liability at the level of the practice, but to go all the way up to the private equity investor through the management services organization. Because what you need to prove under law is that that entity, the defendant, knew of or was in reckless disregard of the conduct that it was directing. So as long as you can show that it was aware of, which in all of these cases I think will be relatively easy to prove, then you could actually assign liability to the very deep pocket at the very top. And the liability under fraud and abuse laws is massive. So that is one potential area of enforcement. And then finally, the last policy, second to the last, sorry. I know I'm talking on and on. Another policy lever, and then I'll get to a final policy lever, would be state laws, right? So states are not without their own levers. I do get questions from states who are like, what can we do, right? We're not Congress, we're not CMS. What can we do if we're worried about this happening within our borders? So because acquisition of physician practices affects the practice of medicine, states are actually very well positioned because they are the traditional regulators of licensing laws, of medical practices, and employment practices, particularly of physicians. So private equity firms commonly use non-compete clauses in their physician contracts that preclude group members from practicing in areas where the firm operates, usually for a prescribed length of time, like 50-mile radius from any of our practice locations for 2 years' time. These non-competes are not unique to private equity, but because these firms use this roll-up strategy, you can imagine that the geographic span of these non-competes is huge for the physicians that are under their control. So the anti-competitive effects and the burden on the physicians can be extreme, meaning if a physician doesn't like the way the practice is being run, they might have to move to another state or several counties over, or to another part of a state if you're in a state like California, in order to practice your profession, because your non-compete basically blocks you from being able to practice anywhere near one of the practice locations for an extensive period of time. So employment laws like these are typically governed under state law, although it also can be addressed by federal law. The FTC has proposed a rule to ban non-competes at the federal level, including for physicians. But state and federal efforts together could regulate and limit the scope of permissible non-competes for physicians in terms of their duration and their scope, or ban them altogether. A similar approach could be taken for non-disclosure agreements. So in addition to non-competes, physicians often sign tight non-disclosure agreements or anti-disparagement agreements that basically are gag clauses that prevent them from speaking out against or even describing the nature of the practices that their corporate owner puts them under. So they basically cannot speak out, they can't talk to the media, they can't complain, and so they're not allowed to leave, they're not allowed to complain. Right? And so we don't have a sense of physicians having any ability to sort of maintain their clinical autonomy and their sort of primacy of clinical authority and decision-making if they are basically locked in as employees and under the thumb of their owner or their management services corporation. So courts traditionally have addressed many of these concerns through what is known as the corporate practice of medicine prohibition. And in brief, what this is a state law doctrine that bars non-professionals like lay corporations from owning or controlling medical practices. So healthcare companies and investors have largely figured out a way to contract around these corporate practice prohibitions. So they've been on the books in 30 plus states for many, many years, but they can basically be circumvented by saying, well, the licensed physicians still own their practice, but the management service company is just going to take the operations off the backs of these physicians in exchange for a management fee or a cut of revenue or both. And so these contractual arrangements circumvent the corporate practice of medicine as they're currently written. So some states are interested in strengthening their corporate practice prohibitions to get at the way these contractual arrangements can control the practice of medicine. And then finally, if you've noticed, none of these policy levers or legal levers have specifically targeted private equity. They are equal opportunity. They would apply just as easily to Amazon. They would apply just as easily to Optum. They would apply just as easily in many cases to health systems, right? It doesn't really matter who the corporate owner is, as long as they're running afoul of these laws, they too would be, if you target the loophole or you target the violation, then you don't have to worry about the identity of the owner. There are a couple policies, however, that are PE specific that I think would also be helpful. One is to close the carried interest loophole. Carried interest is that 20% profit that the private equity investor earns after its hurdle. And so private equity's 20% carried interest is currently taxed at a very favorable rate, let's just say. It's not subject to self-employment taxes. And so there's a lot of policymakers who say, that doesn't make sense. They're earning this money from their active management. It's not that they're just holding an asset and letting it grow. They are involved, and so they should be taxing them at the same rate that other investors are taxed. So one of the things is to kind of equalize or reduce that carried interest loophole. From a tax standpoint, the Inflation Reduction Act of 2022 initially would have narrowed, it wouldn't have fixed it completely, but it would have narrowed this loophole. Kristen Sinema, we can thank her for insisting that it be taken out in exchange for her necessary vote to pass the Inflation Reduction Act. So that's one. Another would be transparency of private equity ownership in healthcare. So there have been a number of House bills that have been proposed this session that would allow and sort of require providers and their owners or managers to publicly report parent company identity ownership, management services contracts, affiliation agreements, and any sort of corporate controls or common controls that might exist in a way to map that ecosystem, which is currently very opaque. And you ask any health services researcher, they have to manually and painstakingly try to connect the dots because there is no one data source that allows anyone to study the effects of private equity. All right, so all of that feels like a lot of whack-a-mole, right? And it is. I mean, that's sort of the downside of, and something that I think is sometimes unsatisfying when I've given this presentation, is everyone wants like a silver bullet. Everyone wants like, well, let's just either uproot private equity altogether or change the system to a single payer system, and then we don't have to worry about any of this. That's another conversation for another day. I'm also getting questions from policymakers of like, what can I do today? Like in the political realm of the next legislative session in my state or in this session of Congress. And so these are really those policy levers and legal levers that we could do today, right? Either with laws that exist on the books right now or small fixes or sharpening that we could do to laws that exist on the books right now, or what policy loopholes should we close if Congress is going to take aim at some of these problems. So that's what this project was about. It wasn't about what sort of systemic reforms could we take at to eradicate financialization in the healthcare system. It's more to say, what are the policy levers we have at hand, immediately available to us, that we could deploy in the fairly short term to get at some of the worst risks? Of course, will any of them solve the problem altogether? No, right? So there is a bit of an unsatisfying solution in that regard. So we know private equity has flooded the market. We know they're not the only ones, right? But they're the leading edge, and whatever they discover, they innovate. Other investors and other types of actors in the market can also follow. This, of course, poses sufficient risks, I think, to warrant a significant policy response. We already have many tools at hand, whether they're existing antitrust laws, existing fraud and abuse laws, to address some of the worst risks of corporate investment in physician practices. Sometimes the tools may need sharpening, and so policymakers can do take some legislative steps, statutory steps, regulatory steps to sharpen. And I think that one of the bigger takeaways just is that the policies really should target those market failures, those payment loopholes themselves, not necessarily targeting, again, the identity of the investor, because the identity today may change tomorrow. Legislation is painfully slow. And so, private equity may have come in and left in that time period. And so you don't really want to be legislating for yesterday's problem, but really close the payment loopholes themselves. Ultimately, these policy levers, of course, are insufficient as a whole to address the larger problem, but they are steps that can be taken relatively immediately in the short term to at least get at some of the worst risks. And I think the final thing that isn't up here, but I just wanted to point out, is that there are levers at every stage of government, at like federal, state, private enforcement is even part of it. There are also levers at the legislative level, at the regulatory level, at the private enforcement level. So there's a little bit of something for everyone. And I think that that is the one thing that I hope is at least empowering to the policymakers and enforcers that I talk to, is that there's a lever, you too have a lever you could pull. And so that is helpful, even though, yes, none of them is going to be a silver bullet for this issue. So with that, I will stop and take questions from the group.
Great. I see we have a hand up. I'm gonna ask a question and then I'm gonna allow other people. So I really appreciate this approach of kind of thinking through what do we have available in current law right now, and it is recognizing that we should, I think, in my view, always have kind of a two-pronged approach, right? Like, what's the incremental strategy that's easier to get past, much more politically feasible, or the policy of just using levers that are already passed, and then what's the long-term strategy, right? And so, but I think when we take this kind of incremental approach, it's important to kind of think about what does incrementalism add up to? And are there some of these levers that add up to something more substantial over time than others? So that's kind of the first question. And then related to that, antitrust law and antitrust enforcement, I think is important. And I'm really glad that under the Biden administration, there's now movement on the roll-ups and changing the threshold. And also this recent lawsuit that you mentioned that implicates PE with in the lawsuit, which is great. But I guess I wondered if you could talk a little bit about, what's your hope that antitrust enforcement against the lawyers that PE can launch against this anemic Federal Trade Commission that doesn't have near the capacity they need to really go up against these behemoths. What faith do you have in that? Are they really going to be able to win that lawsuit and marshal the efforts they need to marshal to actually get anti-competitive behavior out of the system? So,
yeah, I think I'll take your second question first, and then go to the first question. The second question, being, how much hope do we have that antitrust, even in this sort of very promising case, could really move the needle? I think antitrust has to proceed on a case-by-case basis. I think it's an important stake in the ground, right? Particularly if it goes well for the FTC, then I think that would create an important precedent. I think that the risks, of course, are that there'll be a settlement ahead of time, and so we won't get precedent out of it. We won't get a court saying this is anti-competitive, what Welsh Carson did in Texas. So I think that's one risk. And you're right, on the other hand, I guess another risk is that they just out-lawyer the FTC and convince the court that no, this was all totally fine, and look at all these efficiencies that that we were able to unify this fragmented market, and so I guess that would be even a worse risk. But I think you're right that there's only so much you can do through antitrust there's almost nothing you can do through antitrust to restore competition, right? And so a lot of these markets are already very consolidated. I think physician specialty markets are a little bit less so than, say, hospitals, as you probably know. So I think there is some space to protect what little competition what competition remains. But antitrust can't be the solution on its own. It can't restore competition. So what do you do when you have a consolidated market? Well, the only other option, if antitrust can't unwind and re-inject competition into a market, is to regulate that market. And so that's why I think some of the regulatory solutions, which sound wonky and boring, like the Medicare payment policies and things like that, actually have some important implications, because they get at some of the larger, more systemic regulatory constraints on financial engineering opportunities. As far as what are the policies that could maybe add up to something more significant, I think that one of the things is, again, is I kind of am like looking to private equity to find out like, well, what are they afraid of? And so one of the things that they're afraid of is, one, they named this lawsuit against U.S. anesthesia partners is something they are kind of afraid of. So that tells us something, that it could change their, at least the type of their strategy, of their roll-up strategy. And I think they're really afraid of, even though it has like almost no teeth, is the corporate practice of medicine. And so they hate the corporate practice of medicine. And so there's another lawsuit pending in California that tries to use the corporate practice of medicine to go after Envision's really control of emergency physician group out there. And that, to me, and state efforts to try to strengthen the corporate practice of medicine to restore a certain amount of not just clinical decision-making control, but also business operational control to the practicing physicians, not the sort of a figurehead physician who actually just works for the MSO. I think those potentially have the ability of really loosening the controls, not necessarily stifling all of the flow of capital into physician practices, but I guess returning some level of clinical decision-making control to physicians.
Non-compete clause and gag clauses. How would that impact a physician not wanting to be a part of the private equity? That's the first part of my question. And then the second part is, how does all of this impact a physician's ethical obligations?
Yeah, so the physicians have a separate ethical obligation, right, to put patients first. And I think that's a lot of what is explaining the moral distress that physicians are facing, that they're like, I went to medical school and I learned how to put my patients first, and then I get out into practice, and now my boss essentially is telling me to do something different that goes against my ethical obligations. So yes, their ethical obligations are implicated in the sense that they are constantly being put in a bind between choosing between the corporate profit maximization mandates of their boss, who's paying their way, and what they know is best for patient care. Sometimes those are fuzzy, but over time that results in moral distress. What does that do to physicians? It makes them leave the profession, or worse, right? Like they could exit in other ways that we're also hearing of, that there's a mental health crisis among clinicians and frontline workers in the healthcare space. So I think that is certainly, I think, a huge area of concern. And as far as the gag clauses and the sort of other, does that affect their physicians' willingness to sign on the dotted line? Not necessarily. In part, there are a couple of things, I don't know enough about qualitative interviews with physicians who are faced with that decision to really know, but I guess that there's a little bit of both a generational dynamic going on, that the physicians who are like maybe just a few years from retirement, they're trying to find someone to buy their practice. And the young docs don't want to buy their practice. Even if they have a really good practice with a great patient base, young docs coming out of training are like, I do not want to deal with the administrative overhead of practicing medicine under my own independent practice. Like, that's too much. I just want to be an employee. I just want to do patient care. Someone else can deal with all the administrative headaches. So there's no buyer. Hospitals don't necessarily want to buy these practices either. So they say, well, the one who's willing to pay me for my retirement is sometimes a private equity firm. And the private equity firm is sort of like its golden handcuffs. And it's selling this to a retiring physician who's probably going to not be practicing in a few years anyway. And it binds all the subsequent physicians who are part of that practice who just want to be employees, right? They don't realize what they're signing. And they often don't have other options as well. So I think there's a bit of a bind. Physicians don't have a ton of bargaining power. There's a feeling that they ought to push back, and their professional associations are trying to advise them to do so, but very few physicians feel like they can.
Thank you for coming. Actually, a lot of those questions answer the question that I had, but just to kind of like dig deeper into that, like, are there other ways that the private equity firms are acquiring these businesses that are more like, kind of like you're saying, like there's no other option, or like there's, like, I guess how I see it is that like medical practices are already very profitable. So I don't understand why selling to a private equity maybe they don't know the risk of it, but I don't understand why selling to private equity is like more advantageous for them. And I guess like that kind of leads me to think like, are there any on the hospital side, any benefits that they get from a private equity firm owning their business?
Yeah, so on the physician side, I think it goes to that dynamic of the newer generations of physicians do not want to run their own practice. Like, there's like zero appetite to be your own entrepreneur in medicine anymore. And part of that has to do with, frankly, policymakers, like value-based payment and quality bonuses and the move to accountable care organizations and risk, taking on financial risk for your population of patients, all sounds really good until you try to practice under that as like a doc in a practice of 5 physicians or, a physician and 3 nurses. It's really hard to do all of that administrative burden. There's a lot of paperwork, there's a lot of administrative hassle. You can't take on population health. You can't do the data collection and reporting that you need. And frankly, contracting with all those different health insurance companies is just a headache. So for physicians, I think they do see themselves as needing to be part of something bigger so that someone else can take that administrative burden off their plate. And private equity is providing that service. And they're not the only ones. There are other types of corporate investors that provide those management services, and health systems also for different types of specialties are gobbling up physician practices, also having some of these taking advantage of this desire of physicians to try to get out of the administrative burden. So I think that's something that policymakers have to contend with, is like, there's always there's a downside to all of these policy changes. And I think when it comes to what are the advantages of private equity, I think frankly, it's money, like it's capital that it's an access to capital that is needed. And the other is a desire to get out of that administrative burden.
What you just said sort of ties into my question, which is, this is it's a very complicated ecosystem in healthcare and very opaque. Are there, by contrast, you've talked a lot about like what I would call profit farming kind of business models, roll-ups, things like that, where you identify a profit stream and you just go grab it and you hope that they don't catch up with you. Are there appropriate, in your view, having looked at this, could you identify appropriate uses of investment capital in the healthcare ecosystem as a contrast? So are there private equity firms that are kind of not doing roll-ups, but instead investing in things that are net beneficial in any way? I mean, you don't have to defend anybody, but
no,
curious.
I think that's actually an understudied area, because I think that this sort of paints very broadly with a brush of, private equity equals bad financial engineering, but not all private equity firms have that MO, and some are more oriented toward patient outcomes and equity and things like that, but that story isn't told very much. So I think that's something that should be evaluated. I think it complicates the easy political story as PE is the boogeyman, but I think that from just trying to figure out, well, if we want to still have this private capital flow through the system, assuming we do, I don't know if we all do, but it's here, it's going to be hard to uproot it, then how do we put the guardrails around it to maximize valuable investment versus non-valuable investment? And so I think that's a very good question, and probably something that I just don't know. I don't have great examples, but I'm sure, sure they exist.
Thank you so much for the talk. It was so interesting. So my question is, it's out of curiosity. So by listening to your talk, I thought about, is there any geographically, is there any is the impact of private equity firm is geographically distributed differently in terms of rural area and urban area? Because I think maybe private equity firms might have more influence in where the market is big. But at the same time, I also thought about its implication for the access to healthcare in the rural area where there's limited investment in the rural area. Perhaps it can have some good implication for those areas. So I was curious about if you know anything about this.
Yeah, I think actually others, including Professor Brush, have done more research on the sort of geographic distribution of private equity investment. It doesn't seem to, it does seem to pick certain markets and then really grow a footprint there. It's not sort of, again, just like the specialties, it's not evenly distributed, it's strategic. And so it's probably no accident that certain markets have high levels of penetration and other markets have lower levels of penetration. But I don't know if I don't think that there's necessarily on the rural impact. I don't know from a physician practice standpoint whether there's a disparate rural impact, although I'm sure any access issue is going to be exacerbated when you're dealing with a rural health system or a rural community than you are in an urban one. But a lot of, for example, in the U.S. Anesthesia Partners case from the FTC, they focus on these major geographic areas. It was the Dallas area, it was the Houston market, it was the Austin market, partly because of how you can draw and how antitrust enforcers think about geographic markets. But you're right, I think that this could potentially have implications from a cost standpoint for every market, but I don't know about physicians in particular, as being this where I'd be most worried. I'd be worried about some of the other larger facilities in terms of their access, because it doesn't necessarily force physicians to close, right? We're not, unlike hospitals or nursing homes or other things where you could have closure of service lines. What we haven't seen yet necessarily is that private equity buys all of physician practices up and then close the less profitable offices down. And so I think that immediate impact hasn't really hit on physician practices. Mhm.
Piece of this because there's just so much money
Yeah.
being mined there. And I'm wondering, so in terms of federal regulations, we've mentioned FTC a few times, and I'm a lot more familiar with CMS and Health and Human Services, and how they do a lot of fraud investigation, like the Office of Inspector General does a lot of fraud investigation around Medicare fraud and that sort of thing. And I'm wondering, I guess, if there's any interaction between this sort of academic research and an agency like that has the resources to do large-scale investigations like that, and whether the type of research you're involved with and their investigations help inform each other at all, or
Yeah, thank you for that. So I have another vein of research on Medicare Advantage, and I have another whole yes. So the Journal of Health Politics, Policy and Law piece, the one that Colleen mentioned, does at the end, if you scroll all the way through, it's long, but if you scroll at the end, there's a table at the very end that lists policy options to improve Medicare Advantage, in a menu, and it even puts little calculations of Congress, just look, you could save $10 billion a year if you did this, or $2 billion a year if you did that. And so if you need to pay for something, here we've already priced it out for you. So yes, on the one hand, I think that there's a ton that CMS could already do under its existing regulatory authority, things like improving the risk coding, the coding intensity adjuster, or doing more to recoup overpayments that are improperly coded. And that there's a lot of interest in doing, at least in the academic side of look, you're leaving money on the table. And this CMS, which is, I think, every CMS has different priorities, but this one, with its recent rulemakings on, risk adjustment, data validation, RADV audit policy, and extrapolation, and all of this wonky stuff about how it's going to try to recoup overpayments from past overpayments. It's sort of moving in half measures, right? It's sort of we're going to do this thing called extrapolation, where we're great, and then they're oh, but we're only going to do it back to plan year 2011 and not 2008, because they're afraid of the Medicare Advantage plans. And the Medicare Advantage plans really have the ear of Medicare, unfortunately. I think there's a bit of capture going on there. I also think that they get screamed at. CMS gets screamed at by MA plans all the time. And so what we've heard from Medicare CMS officials is someone needs to scream on the other side. And that's, I think, what not just the advocacy organizations, but I think some of the researchers, that's I guess our role is if they like put something out for comment and they're getting like 1,000 comments from all the Medicare Advantage plans saying like, you're evil, you're gonna ruin us, then they need like, academics to say, no, here's the literature and here's sort of why it's important that you do this, and frankly, you should do more. So that's sort of, I mean, I know it's a little bit like David versus Goliath a little bit, but that's what we're trying to do, is engage CMS directly and then maybe engage Congress as well. Of like, there are things CMS can only do on its own. And then there are things that Congress has to pass a different statute to change, quality bonus payments from the way it's currently structured to be more efficient, things like that. Yeah.
So I've been seeing a lot of value-driven healthcare articles, a good amount. All of a sudden, we've decided that prevention actually may be beneficial. And I'm seeing a number of private equity firms or people who work for private equity deciding to weigh in as an opinion expert. And my question basically is, and this may just be getting your opinion, but given your landscape, what loophole, if any, are they exploiting? Are they just trying to get good publicity? Or is there so much pushback from people saying you could have prevented various conditions, and this now is getting to the point where the scale is tipping with too many sick people in the United States? Is it none of that? Is it something else?
Yeah, I don't think private equity is getting into the value-based payment model because of the good of their hearts or even for PR purposes. There has to be a revenue strategy in there. So I'm with you. The revenue strategy from what we can tell thus far is a Medicare Advantage game, right? So value-based payment is it's sort of the solution to the dysfunction of a fee-for-service payment model. We're going to pay for value instead of volume. Medicare in particular has been leading the charge on moving from a fee-for-service model to more increasingly to a value-based payment model. Medicare Advantage is sort of the ultimate value-based payment model in that it pays on a capitated basis. It pays on a per beneficiary per month basis. However, if you're an MA plan, you can get more per beneficiary per month if you code their diagnoses extensively. And that is the game. That is like 100% the game. And so they want to get into the value-based payment, whether it's the ACOs or the Medicare Advantage capitated payments. Why? Because if they then own the data, they own the home health company, they own the primary care. As Medicare Advantage is like, we're going to encounter-based data. Well, how do you create an encounter? You own the primary care physician who sees that patient. You own the home health provider who makes that visit to the Medicare Advantage beneficiary's home to ask them a questionnaire. Why? Not to provide follow-up care for their diabetes, not to ensure that they're getting all the care they need. It's so that they can document in an encounter all the diagnoses and all the comorbidities this person has so they can get a bigger payment from Medicare Advantage. It's just a one-to-one. So yes, that's the game. Which doesn't, again, it's not like value-based payment is evil, but it's like, it too can be gamed. And you can bet that is exactly what is, there's a lot of money to be made from it.
Thank you for this really compelling and just impressively comprehensive lecture. People on Zoom are already messaging me that, this has been such a treat to have you here. I think on going outside of just private equity, it seems to me like some of the impact of your work really comes about because you are able to take, say, what health services and public health researchers offer and really add the legal acumen that they simply don't have, that we simply don't have, and really think beyond just a couple bullet points to actually real concrete legal policies. And so what type of synergies or what type of scholarly ecosystems do you think can be created between more legal communities who are doing health law with traditional health services, public health researchers? Because it seems like what you've been able to do, you've really advanced the field in a way that without your legal acumen, it would only get to certain levels. So what are the recommendations you give?
So there are a couple. One is sort of from where you sit, and then one is the structural, right? So from the where you sit, I think it is really important to kind of build the bench in terms of to find health law and policy experts, like people who are academics in law, but who could partner with health services researchers to do that legal translation piece. I think like I was basically just approached by a health services researchers like, do you want to collaborate on stuff? And I was like, yes, that's great. I want to do evidence-based policy recommendations. You want real legal, heft behind your recommendations. It's great. And it's not hard to do. It's about finding those partnerships and creating them, which gets me to the structural issue, which is we need to convince funders to fund the legal piece, the translation piece, because law academics are not generally part of the funding ecosystem, whether it's through NIH or through even increasingly through some of the private foundations. But even then, a lot of the research there's not like an incentive or a lane to kind of create this body of work and to encourage these collaborations. So one is to create those partnerships, and I can help make introductions to my legal colleagues who would be eager to do this kind of work. But also I think that the funders, the powers that be, need to learn that this is an important collaboration to fund, that it is something that legal scholars are actually fundable too, especially in collaboration with the health services researchers. All right.
Okay, are there any questions on,
We have several online, but I'll just forward them.
okay. Any more questions in the room? Yeah. We have about 5 minutes left.
As somebody who's on Medicare, just on traditional Medicare, and I looked at Medicare Advantage, and it seems like there's really a heavy-duty push to get everybody into Medicare Advantage. In fact, the magazine AARP did a study, and they said that more than 50% of people are signing up for Medicare Advantage, and the main reason they sort of attribute it to, or one of the reasons, is that the people that the advisors are paid more if they sign you up for Medicare Advantage. And whereas they said that care-wise, you're probably better off with just the traditional Medicare. Why are we letting this go on? I don't know. It seems like if we've got a better system to cover people, we put all these intermediaries. Each time you have to re-sign up, there's hundreds of people that contact me to try to get me to change to Medicare Advantage, which is a waste of our resources.
Yeah.
Why don't we just get those resources out of there and just pay for the health care?
Yeah, and I think like anything, it's not a satisfying answer, but part of the problem is we don't really know the extent of the problem. There's not a lot of transparency on the role of brokers and the commissions that they earn and how they steer potential beneficiaries and how sticky that initial choice is, right? Because I think people are kind of under the impression like, oh, I can sign up for Medicare Advantage because it works for me now when I'm 65 and relatively healthy, and I want my gym membership and I want my vision and dental, and it's $0 premium. It's like, what could possibly go wrong? Well, fast forward 20 years and you need, you have a much more complex health condition, you have something that you need to manage, and suddenly you're limited to your health plan, Medicare Advantage plans provider network. There's prior authorization. There are all sorts of things that you start running up against if you need more care that beneficiaries don't realize. And they're like, well, maybe I can switch to traditional Medicare now. Well, good luck if you're trying to buy a Medigap plan, which are not community rated. So you're basically priced out of buying a plan, Medigap supplemental benefit coverage to cover everything that Medicare doesn't cover, which is a lot, right? So I think, Medicare beneficiaries certainly don't know how to make sense of all of the marketing that's coming their way. And I don't know how much study there is being done on the extent to which that marketing is driving choices by Medicare beneficiaries, and how trapped or how much switching can actually be accomplished later in life if it turns out not to be a good plan. So I think that there is that, but I think there's also just like it's a fundamental question about the role of privatization in something like a publicly funded program like Medicare. And I think we're still having debates where even among, people who study this all the time, there's a disagreement about whether private insurance plans have efficiencies and things and benefits to bring, or whether or not they're just sort of sucking all the profit out of the taxpayer-funded Medicare Trust Fund for their own benefit and not for the benefit of the beneficiary. And left out of all of these conversations is like real advice for someone who's like, given your health needs, given your profile, what would be a good choice for someone who's 65 and faced with an array of bombardment of marketing claims, frankly, by brokers. I think that needs to be a bigger part of the picture. But then the problem is once they're enrolled in a Medicare Advantage plan, the beneficiary from a political standpoint becomes a defender of the Medicare Advantage plan. And Medicare Advantage is very good at mobilizing their beneficiaries by scaring them and saying, CMS is planning to do more, risk adjustment audits. This is a cut to us. It's going to mean worse, benefits for our Medicare beneficiaries. Go to Congress and fight, or go to CMS and tell them you don't want this. So from a political standpoint, the more Medicare Advantage enrollment there is, not only does it skew the payment model and threaten the financial sustainability of the Medicare program, it also creates an army of defenders of the Medicare Advantage plan who are afraid of change or of being forced into something that they didn't choose. Yeah. That's a good question. I don't know if private equity has entered the teaching hospital. I would say it looks like yes. Yeah. There is no place that they have not entered. Yeah.
With that, let's give a warm round of applause for.
Thank you for having me.